Okay, coming up here, last presentation before lunch is a panel that is chaired by the Honorable Bill Illenfeld from the Northern District of West Virginia. The panel is on the operation and networking of prescription drug monitoring systems and the implementation successes that we have there. Let me introduce the panel. Bill's already here. I'm looking for Bill. He's here behind me. Amanda Ward is the pharmacist consultant for the Kentucky Cabinet for Health and Family Services, the Office of Inspector General, Drug Enforcement and Professional Practices Branch in the state of Kentucky. Dr. Mitchell Mutter is the Medical Director for Special Projects at the Tennessee Department of Health. Mike Gough is the Program Administrator, West Virginia Controlled Substances Monitoring Program, the West Virginia Board of Pharmacy. Dr. Ralph Orr is the Director of the Virginia Prescription Monitoring Program. And Dr. David Walker, who spoke with you earlier, of course, is the Deputy Chief of Staff of the Robley Rex VA Center in Louisville. So if you would welcome those folks to the stage.
Thank you, Bill. We'll go ahead and get started. We've got a terrific panel here to discuss a very important piece of the big picture. And you all have the bios and the names within your material, so I'm not going to go through that in great detail. What I want to do, though, to get started is to let each of our panelists speak for a few minutes about who they are, what they do. Each panelist has a few slides that they'd like to share with you. Once they've gone through their introductions and once they explain to you a little bit about the system that they work with in their particular state, then we have some topics we're going to cover. We'll have some back and forth among the panelists, and then we'll also open it up to the audience and let all of you ask whatever questions you may have, and then we'll get to lunch. So let's go ahead and start with Amanda Ward. She's got some slides to share with you, and she'll go ahead and introduce herself to you.
Thank you. Is it on? I'm Amanda Ward with the Kentucky Cabinet for Health and Family Services, which houses the CASPR program. I am a pharmacist. My title with the cabinet is Pharmacist Consultant / Investigator. CASPR is Kentucky's prescription monitoring program. It tracks any Schedule II through 5 controlled substance prescription dispensed in Kentucky. Right now, our data is anywhere from 1 to 3 days old, and this went into effect July 1st. Effective then, dispensers must report within 1 day of dispensing. Prior to that, they had 7 days. Everything had to be reported within 7 days. Or once every 7 days. So there was a little bit more of a lag time with the data, and now, as you can see, our data is anywhere from 1 to 3 days old, so that has significantly improved. About 96% of our reports are available within 15 seconds from any computer with web access. And we've recently undergone some improvements in the technology, so that number is up from about 92% now to 96%. CASPR, like any prescription monitoring program, was designed as a tool to help address prescription drug abuse and diversion by providing a resource to healthcare professionals and to law enforcement. It was never intended to prevent people from obtaining prescription drugs or to decrease the number of doses dispensed. When I go out and do trainings, I always tell providers, think of a CASPR report just like you do a lab report that you get back. Use it as a tool to guide your patient interaction. Don't use it as a hard stop. House Bill 1, which we've already heard a little bit about, was affectionately called the Pill Mill Bill in Kentucky, passed last year in 2012, went into effect on July 20th. There was additional legislation passed this year, which cleaned up some of the language but still left the intent of the bill the same. As we've mentioned, dispensers must report within 1 business day. CASPR registration is mandatory for Kentucky practitioners or pharmacists who can prescribe or dispense controlled substances to humans. So veterinarians got out of that, and now we don't have all the veterinarian data coming into CASPR as well. CASPR has to be queried before prescribing a C2 or a C3 containing hydrocodone. As Dr. Walker mentioned, the additional licensure boards had to promulgate additional rules and exceptions to this. Prescribers can obtain a CASPR report on themselves to identify fraudulent scripts. Right now, that's only for a 30-day window at a time, but they can go back in 30-day increments to view their CASPR history. And they can give the patient a copy of their CASPR report and place that in the medical record. A few statistics about CASPR program. As you can see, since practitioners and pharmacists are required by law to have a CASPR account, they make up the vast majority of our CASPR account holders. This shows data from 2006 to 2012, how many prescriptions are reported to CASPR annually. So 2012, 11.91 million records were reported to CASPR. In the first quarter of 2013, we've had over 2.7 million records reported to CASPR. And the number at the bottom is the number of controlled substance prescriptions per person in Kentucky, regardless of age. So every person in Kentucky, regardless of age, in 2012 received 2.72 controlled substance prescriptions. This is very interesting because you can see that House Bill 1 had a definite impact on CASPR reports that were requested. And keep in mind, the House Bill 1 did not go into effect until July 20th. That number is very, very high. So far in 2013, we've had 2.3 million CASPR reports be requested. We're anticipating for the entire year of 2013 that number to be over 4.5 million. Top 10 controlled substances in Kentucky. Number 1 for us is hydrocodone, followed by oxycodone and Xanax, and the others at less than 10%. This is some very interesting data. The University of Kentucky is conducting a study that started July 1st of this year and hopefully will be completed by July 1st of next year to determine the impact of House Bill 1 on prescription drug abuse and diversion in Kentucky, identify any unintended consequences of the legislation, and identify ways to address those unintended consequences. So as you can see, August 2011 through July 2012 is kind of a pre and post House Bill 1, if you will. And for the most part, we did see a decrease in the doses dispensed of the controlled substances. And with that, I will pass the mic.
Next, we'll have Dr. Walker, who you heard from earlier, and he's back with us for this panel.
Okay, well, it's a repeat. The other slides are in there, but I'll just speak to 2 slides or 2, and then you can go ahead if you want and just fast forward through all those. The main issue with prescription drug monitoring that I wanted to point out today is the drug testing. What happens is that when a person is taking a prescription, it's very likely for many of these substances that they have what's called an active metabolite, or in other words, the metabolite is different enough so you take one drug but you might have 2 in your urine. And so knowing which medicines the person is on and then what other drugs you may see in when you're drug testing is very important, because if you don't know that, it'll look like the person's, are they using something they're not supposed to be. And so that is critical, because many of the point of care, so i.e. at the doctor's office or at a substance abuse clinic, the little dipstick in the urine, those have real limitations to them. The other is the benzodiazepines. That's the drugs like Ativan, Valium, Xanax. Certainly, addictive drugs, you can have seizures when you come off them if you've been on them enough. But the problem is they're even more complicated in the drug testing arena, because there's no one standard for which of those type drugs should be set. So you can have somebody who will show up not having it in their system, but they may actually have it. It depends upon what the lab is using as its standard to test. And then most of the labs don't test for that actual drug. They test for one of the many metabolites, and some of these drugs have common metabolites, some don't. And so for drug testing of that class of drug, you have to work closely with your lab. And there's no standard for what level is a positive. And so testing benzodiazepines or the anxiety medicines is not straightforward. And in a prescription drug monitoring program, the results of drug testing will oftentimes lead, to the drug being stopped or certainly discontinued. And so one has to be on top of their drug testing lab and what they're using and what they're actually testing for when they're involved in this. So I'll leave it at that. Okay. Let's see. I'll go through these.
Next, we will hear from Michael Gough. He is the program administrator for the state of West Virginia's Controlled Substance Monitoring Program.
My background is in chemistry. I started off in our forensic lab. I progressed through my career into the meth lab business. I was in that for several years, and I retired, and I've moved on to the controlled substance monitoring business at the Board of Pharmacy system. I've been there about a year now, and I'm still learning a lot of stuff, mainly because we just went into a new phase of a database. We went from a 1997 format system to a 2013, the ASAP 4.2 format, which is if you think about a cell phone that was 1997, what it looked like compared to a cell phone today, the improvements in technology have been about the same. Very much like a lot of the monitoring programs, we track Schedule 2s through 4s, and each of the histories contains all the information from the prescriber, the patient, and the point of dispensing where the information actually is entered into our system. All that is queryable by the law enforcement as well as our administration. The prescribers and the dispensers all clearly can only see patients, but some of the boards and other entities that have access to our system can do a number of different searches. We have 24-hour reporting now. It went from 7 days to 24-hour. We're still catching up to the upgrade. Some of the folks who are still lucky to get weekly, we're still chasing those down occasionally. There's a lot more fields that are collected that are accessible. The method of payment's a big one. Some of the cash transactions are now identified in our system as that. In addition to the Medicaid, Medicare insurance, and different types of field required. We're in the process. The new system, part of the upgrades, is required for us to access and connect with the PMPI, the national hub that's been mentioned a few times, where you can actually look at other states' prescription information and collate it into one report in our system. That's real close. It's definitely by the end of the year, hopefully within the next month, we'll be online with that. Our data, when we pull it out of the system, some of it, you can see it, and it's this big spreadsheet full of information. It's hard to manipulate. We can save in a number of different formats, including Excel, so you can sort and actually break it down and look at it more in a more precise manner. And we have better audit trails with the new system. We can check who's been searching, if someone's doing something improperly. We're trying to spread out the registrations more, where the master account holder being the physician or the prescriber and the dispensers, and then people under them have their own access where we can identify exactly who's doing the searches instead of just one pharmacy access that we had previously. Similar to Kentucky, there's no surprise that hydrocodone is number one. Some of the other smaller components are a little bit varying from state to state, and this is based on a little over 5 million dispensings out of our state in 2012. And if you notice, if you combine all the benzodiazepines, it's about the same as hydrocodone, so we have a lot of multiple dispensings in our state. Our queries are getting close to 1 million now, and we're a little bit heavy on the dispenser queries. We have, actually, the dispensers are looking more than the prescribers, but our code requires that all dispensers and prescribers to have access, and only requires access when you're prescribing, pain medications in certain instances. It's not a requirement every time.
Thank you, Mike. And next we will hear from Ralph Orr. He is the director of Virginia's Prescription Monitoring Program.
Going back the wrong way?
A couple more for Mike. I think you want to comment on those? Or are you all right?
Well, I come from the meth lab business, and it's kind of a transition into the controlled substance monitoring. The Board of Pharmacy fully supports the prescription only of pseudoephedrine. That's the only way to significantly reduce the number of meth labs. We're on pace. We're already at a record high, and we're still climbing. The numbers, I haven't seen the local numbers here, but they're going up in a lot of areas. And we've tried the different tracking systems, and we've tried other programs, but it seems like controlling the pseudoephedrine by prescription is the best way to do it.
Okay, for the Virginia Prescription Monitoring Program, we really focus an awful lot on our prescribers and dispensers, but our law enforcement folks also have access. So that's why we have on almost all of our stuff that when we're doing that marketing, minimizing risk, maximizing management, because we want to talk in a healthcare mode. We began as a pilot program in September of 2003 as a result of, the hillbilly heroin epidemic. 60 Minutes showed up in Southwest Virginia in 2001, and legislation was passed in 2002. The pilot program existed just in a few counties in Southwest Virginia. It was really totally a facts-based system. Our database was Access. That was it. We had a web form where we used to develop queries, and we did an evaluation and finally got law passed to go statewide in 2005. The system actually went statewide in 2006, but in 2009 is when we really hit the big time. We initiated 24/7 auto response software in September of 2009, and just to let you know the impact of what technology can be. For 2009, the total was 75,000 requests. 2010, we had 433,000 requests. 2011, over 600,000. In 2012, over 800,000. In 2011, Virginia became one of the first 3 states in the nation to be interoperable with another state program. 2012, we added a couple reporting requirements, such as method of payment and whether a prescription is a new or refill. We had a lot of questions from our users that said that would really help us read these reports. And this past year, we've always had access for law enforcement, but for local law enforcement, it was really state police, drug diversion agents. We have 22 in the whole Commonwealth of Virginia. And this last year, legislation was brought forward, and we added local law enforcement, who are drug diversion investigators, designated by their chief of police or chief of sheriffs or whatever it is. And they also have to completed the state police drug diversion school, which we felt was a very big, important thing to increase access. And so the next thing, statistics. As of September, as of today, we're over 900,000 requests for 2013. We thought we were going to do about 1.2 million requests. We're going to probably hit 1.3, 1.4 the way it's looking. We have over 17,000 registered users. About, I'd say, 30% of prescribers. We're over 50% of our pharmacists are registered to use the program, and we do not have mandatory requests or registrations in Virginia at this time. And we have over 94 million records in our database. We collect over 1.1 million records every single month. So, and that's with a population of 8.5 million. So the biggest thing that we've engaged in is interoperability. We hear a lot about that. We're now sharing data with 13 states. In August, we turned on Tennessee, which we were extremely happy to have happen. And I know Tennessee was very happy with that, too. We are looking very much, interoperability you would think would be simple. It's not. There are technology challenges that occur, and there are nuances in law and regulations which create roadblocks that are totally unintended, but sometimes, as probably a lot of you recognize, sometimes laws and regulations do take a little bit of time to overcome. So we'll be very glad to get West Virginia when you're ready, and we're working very hard to get in Kentucky on connected also. Projects. One of the big things, the prescription monitoring program is housed in the Department of Health Professions, which is an umbrella agency. We have 13 licensing boards, which include the boards of medicine, nursing, dentistry, pharmacy, all the health boards. So we are working on a project where instead of having to have a prescriber or a pharmacist actually register to use our program separately, we're going to use our renewal process. And when they renew their license, if they're not already registered, they'll be registered. So that's a big project. We are very interested in integration with health information technology applications. You heard a little bit before about some of the pilot programs that SAMHSA and ONC did in some other states. We hope in 2014 we're going to be doing one with our HIE called Connect Virginia, and also with at least one of our health systems. We're also looking at the development of an online resource center, and one of our biggest projects is to try and take those 94 million prescription records that we have and develop some data sets that people like Professor Pack and others can actually use to look at some of the data over a time period and see and be able to track that stuff. So it's those are the big things. My contact information is there, and we're good.
Thank you, Ralph. Next, we'll hear from Dr. Mitchell Mutter. He is the Medical Director for Special Projects for the Tennessee Department of Health.
Yeah, that's right.
All of our programs have have great things in common, but some things different. Our program really started in 2002, and they really didn't start entering data into the database until 2007. These were elective enrollments in the database. In 2012, the Prescription Safety Act was passed, and the Safety Act required 100% of prescribers with the DEA to enroll in the database. That started January of this year. Then in April 1st this year, after writing a prescription of greater than 7 days, you had to query the database ahead of time. So that was mandatory. Our queries went from 1.2 million a year up to about, on track to about 4 million this year. Now it's the required. So with 33,000 prescribers and dispensers in the database, we have a pretty robust program. One thing that we went from monthly submissions to the database to 7 days, and we soon should be going to, my IT people tell me I shouldn't say real time. There's no such thing as real time, but near time enrollments in the database, so that should be coming soon. We also now are recording methods of payment, which is very important for us in tracking because our pain clinics no longer can use cash payments. We have a CSMD committee, a database committee. This really is made up of all of the regulatory stakeholders, and they really serve as the operations manual of our law. The commissioner has authority by rulemaking hearing to change some of the things like medical director requirements, quality, but the legislature does a great deal of changing things like the number of pain clinics that can really exist. I'm going to pass over this for the sake of time. We have now in Tennessee 219 pain clinics. and you can see that access is an issue, so they're all along the interstate. You also can see that a great number of those are from Hamilton County eastward. When we look at Sullivan County, Washington County, Knox County, and Hamilton County, we see a very large number. When we break that down into pain clinics per capita, then some of the smaller counties like Grundy County have very high numbers of pain clinic access. To put that in perspective, the population of Tennessee is 6.4 million. We have more pain clinics than the state of Florida does now with their recent legislation, and Florida has less than 300, and their population is 4 times larger than the population in the state of Tennessee. Obviously, this is something we need to work on. So these are our DEAs. The public chapter 430 required that we write chronic pain guidelines and have it by 1 January this year. We're on track to get that done. We have stakeholders, regulatory people on the panel, as well as a panel of experts. A number of you in the audience are on that panel. We met for the 3rd or 4th time Friday the 13th of September, and we're on track to have that by the 1st of January, our chronic pain guidelines, which will be adopted by our regulatory boards, and then use that as the standard of care for the treatment of pain in the state of Tennessee. These are some of the chapters. Basically, it's looking at what kind of evaluation you need prior to implementing opioid therapy, and obviously non-opioid uses need to be considered before using opioids. Number 2, what you do on initiation, and number 3, the chronic tracking and follow-up. We anticipate that the actual document will be something around 5 to 8 pages, but the appendices, which address special issues such as the pediatric population, we see a skyrocketing number of pediatric prescriptions written in the state. So we'll address that, as well as things like neonatal abstinence. And a big argument in our state has to do with definitions, what constitutes a pain specialist. And stay tuned for that. I don't know what constitutes a pain specialist. So these are some of the appendices that we'll have. We will have on our new CSMD site some enhancements coming out 1st of October, and the enhancement will include a morphine equivalence calculator, and not only that, it will, when you bring up your patient, it'll tell you how many morphine equivalents your patient is receiving, so that we will start doing push notifications to prescribers to emphasize that with various things, and we look to create risk models to what the high-risk patient is, the high-risk prescriber is, so that we can do push notifications as we move forward. That'll be coming in the next few months. I think we can stop there for discussion.
Hold on to the microphone, Dr. Mutter. I've got a question for the whole panel, but I'd like you to take the first crack at it. We've all heard about the positives of each of your systems in your respective states. Are there any weaknesses that you perceive within Tennessee's system? And second part to that question is there a way for your legislature to perhaps fix that weakness?
Well, I think the greatest weakness of our system, and this is excluding the pain clinic problem, but is the fact that our legislature made our CSMD more private than HIPAA. So what happens is that our physicians, prescribers, or mid-level providers are told by the State Volunteer Mutual Insurance Company not to put that on the chart. And to me, that's like saying don't put an MRI on the chart. It's very important data, because I truly believe that it will be a malpractice issue if you don't have it on the chart in the future. For example, reviewing a chart with someone on 400 morphine equivalents a day, and goes in the hospital for elective surgery and receives post-operatively 30 morphine equivalents, and they have withdrawal symptoms and complications. So I think the paradigm will shift, but our legislature hopefully will address this the next session.
Dr. Walker?
I think in Kentucky, we have a requirement that if you expect diversion, you need to contact the provider that's listed. And our biggest challenge is that you may have a name and a city, but that's it. And so if it's a metro area and a common name, you're put in the position of calling, asking, and certainly from a HIPAA standpoint, it's just one challenge that I think can be worked on.
We get asked all the time in Virginia, why don't we have mandatory requests or mandatory registrations? And it may come, it may not, but I will tell you that at the highest level of prescribing, those prescribers are actually 85% of them are registered to use our program at the top. So, I'm just saying that we do have some positive things there. The biggest thing that I see as a weakness, and which really goes to this whole piece about mandatory requests, is we look at integration into workflows for healthcare providers as the biggest key to actual use and good use of P&P data. So if we can integrate it into their workflow so that they don't have to have a separate password and account and all this other stuff, get it in there, make it available, make sure the information is timely and complete and easy to understand, that is the key.
Similarly, we have issues in West Virginia where it's more of an education issue. They don't know how to use the program maybe, or if they see the results, how to interpret what that means and what is excessive, why in certain instances they maybe not write the next prescription or seek other sorts of treatment. But that's the issue here, is we're getting the numbers of folks required to access or required to have access, but getting them to actually use it and getting to understand what they're looking at. We also have the abilities for the prescribers and dispensers to pass along information that they feel is improper or questionable to law enforcement. It's specifically spelled out they can do that, but we have also the limitation on who are those folks in their area. The education is not out there on what to do if they find these people, how to describe them, how to identify them, and then what to do with them when they do identify them, how to pass it along to the appropriate officials.
I think for us, keeping up with technology is always a constant issue, as with any PMP. And also quality of the data that's submitted. We are requiring the data to be submitted, but how accurate is that information that the dispensers are reporting? How accurate, is the patient giving them the correct birthday or not? So some type of issue with that.
Amanda, let me ask you this. We spoke before today, and we discussed the attempts to perhaps circumvent the CASPR system. Have you seen any instances of folks who have tried to get around the system who aren't complying?
We've got some prescribers that are dispensing out of their offices that we find out because somebody else rats them out. We find out that way that they're not doing their diligence with reporting the data to CASPR. And we also find out the same way with doctor shoppers. Well, why didn't this prescriber catch it? Are they running CASPR reports? And so people kind of like to rat each other out, and they give us the information that way, and they are trying to circumvent the system.
There was a slide that Dr. Mutter provided, we didn't get to it today, that was interesting. It talked about the way the system in Tennessee has changed the way doctors practice medicine. And the statistic was, out of about 800 doctors surveyed, over 36% said that they are less likely to prescribe. 38% said they have not changed the way that they're practicing medicine. But that group that says they're less likely to prescribe, can you talk about that issue, both you and Dr. Walker, and how it's perhaps changed the practice of medicine in your states?
I think the unintended consequences to the law is that we really want our primary care physicians prescribing, treating their patients, and they've seen this as so cumbersome. But as I go around the state, hopefully that number will reduce, because they just want to send people to pain clinics. And in our guidelines, it's going to say basically over 100 morphine equivalents, and by our data shows that the risk of overdose death goes up 13.2 times higher than the rest of the population for overdose deaths. So when it gets to that 100 morphine equivalents, we recommend that the primary care physician refers to a pain specialist or a psychiatrist if they're on other kinds of drugs like benzodiazepines. But yes, there's a large body of primary care physicians who have treated chronic pain and have referred those to pain clinics. And I would dare say that probably 100 of our pain clinics are pain clinics, and the rest of them are pill mills with a name on it.
Dr. Walker?
Well, in our system, we have a pain clinic, but it's really become a procedure clinic, so for injections. And so it's not, it's different than what you would expect Casper to pick up. And then it's going to be, injections into the areas in the spine or into nerves. The issue with certain providers not wanting to prescribe or prescribing less often, that's certainly been the case. And then I think lastly, there's been an issue where in our more rural areas where you would have the primary care doctor doing some of the psychiatric treatment, now we're seeing that they don't want to do the psychiatric treatment. They want to just focus on primary care medical problems. And I could see that in rural areas being really a challenge.
We're getting close to the end here, so if anyone has any questions, feel free to jump in. I've got a few more topics I'm going to cover. Yes, ma'am.
Dentists, because there are two kinds of dentists. One is a dentist that actually dispenses out of his office. He or she has to enter that in the database. But then there's the dentist that writes a prescription, and it goes to the database via the pharmacist. Now, we do have 33,000 prescribers that are registered, and part of those are dentists. But we know our system's not perfect. When we sent out the top 50 letters to the top 50 prescribers out of 30,000 prescribers, 7 of those were not registered in the database. So we're finding things all the time. So that is very important. One of the ways we're closing the loop on dispensers in doctors' offices is that our legislature passed an ARCOS kind of law that we're supposed to be getting reporting of manufacturers or wholesalers selling to physicians' offices so that we can track that down. At the national meeting, it appeared that closed the loop in terms of the whole paradigm of substance abuse with the ARCOS data and also the pharmacy data.
My understanding in Kentucky is that dentists, if they're prescribing less than 3 days after a procedure, don't have to query the database. And our VA, any prescription written is still uploaded, but if it's less than a 3-day supply, the dentists aren't looking at the database. Is that your understanding in Kentucky?
One of the things we found out, and I've gotten a new title, and it's called Provoker. And so one of the things we found out is that we have a physician in the state with 12 DEAs. We have a dentist in the state with 6 DEAs. We're trying to find out why that's important. We're in touch with the DEA, and it is that every place you dispense out of, you're supposed to have a DEA, but those numbers seem a little bit high, so we're working on every problem we think we solve, we create problems. And the other is we have found in terms of doctor shopping that our numbers are declining in the state of Tennessee, and doctor shopping for us is defined as 4 providers 4 pharmacies within a year. So that, with that definition, it's declining.
And Ralph, what about in Virginia with regard to doctor shopping? What trend have you seen?
With the doctor shopping?
Yes.
Yeah, over the past few years, we've seen a significant decrease in doctor shopping indicators at the highest level. Of course, we still send out unsolicited reports to prescribers periodically, and a couple years ago we got the authority to send unsolicited reports to state police, law enforcement. So we're seeing some positive action on that.
Mike?
The upgrades to our new system allow us now to do some of these queries to find the doctor shoppers, and the governor's Senate Bill 437 also created an advisory committee which is comprised of physicians, pharmacists, various specialties, where they actually come up with parameters to look at the CSMP with, and then refer them to a database review committee, which is the other physicians and attorneys, prosecuting attorneys, to see what to do with those folks. And we're starting to look at, we're starting at 6 physicians and 4 dispensings in a year, and we haven't physically got that data yet, but I predict it's going to be astronomical, and we're going to have to raise our numbers a lot higher to actually get a manageable number of what we consider doctor shoppers.
I think the doctor shoppers in Kentucky are down because of the daily reporting. So if the practitioners are fulfilling their end of the obligation, then they're checking and seeing that they're going to multiple providers, unless they're hitting all of the providers in one day. Then we don't have that ability to track that yet.
What is, out of each of those databases, what's law enforcement's access to each of those?
Law enforcement can request a CASPER report. You can have a CASPER account and request a CASPER report.
In West Virginia, law enforcement has direct access to the system. It's specified as being DEA, West Virginia State Police officer who have basically a letter from the superintendent granting them permission, and local and city officers, county and city officers can have if they're a member of a federally recognized drug task force. And on top of that, they have to have specific required diversion training before they can have access. We're working on a system where we have a national data or a statewide database where law enforcement agencies can request varying types of information during different types of investigations. We're trying to include a request to grant their controlled substance monitoring histories as part of a regular information request.
In Virginia, we have access for federal law enforcement agents who are conducting drug diversion investigations, state police drug diversion agents, and as I said before, the local law enforcement people who are doing drug diversion. We also allow our regulatory, we have a enforcement branch in our department, and they have access, and also our Office of the Chief Medical Examiner has access. And I think the other one that you probably are concerned about is the Medicaid Fraud Control Unit and our people with our Medicaid services.
Our database is housed by the Department of Health and the Department of Pharmacy, so therefore it's a little more user-friendly, I think, to the medical community and less user-friendly to the law enforcement, although any open case can get access to the database, and we're creating a computer enhancement so that this can be computerized and done in real time so that we can save time in the request and the return on the request. Now the DEA, as in most states, I think still issues a subpoena for any records that they want.
Yes, ma'am.
A question for Dr. Mutter. How did Tennessee manage to ban cash payments to pain clinics?
The pain clinic, they could use money orders, but with this recent law, the cash payments are not permitted, and we see self-pay patients. I just reviewed some records yesterday morning, and that's a violation. We go in, we send in our investigators. One of our best is here, Dr. Charles Whitson. I don't see him right now. He must be playing hooky. Anyway, he goes in and he checks for that, and we have an audit of pain clinics that we do so many every month. We audit or do investigations, and cash payments is one of those things we look for, along with other things like medical director on site. Cash payments, anybody?
One more question on that issue, Dr. Mutter. Have you seen instances of noncompliance with doctors in Tennessee, and what are the administrative remedies that you have available within your system to address those?
Yes, we've seen noncompliance. It's, although I think it's with the numbers of 30,000 and 30,000, it looks like we have 100% compliance. But then I told you about the 12 DEAs, so it obviously looks like that person knocks out 11. The other part of the misleading number is that to make our database more user-friendly, any licensed person in the state can be under a physician's DEA and query the database for him. And then 2 unlicensed, such as a medical assistant, can query the database for that physician and have that data for the physician, so that when he or she sees the patient, it'll be much quicker. So those numbers are better, but no, we do have folks that are non-compliant. And when we send, of all things, when you send out a letter to the top 50 prescribers in the state, and 7 out of the 50 aren't even registered, and that's, I think, is mind-boggling.
Please join me in thanking this panel.